Good afternoon, everybody. Welcome to the Sedana session on inhaled sedation. My name is Danny Talmore from Boston in the United States, and co-chairing with me is Kerstin Röhm from Ludwigshafen in Germany, and she is also our first speaker. So, why inhaled sedation makes sense for the critically ill patient, facilitating the ABCDEF bundle. Please welcome Kerstin.
Thank you, Daniel, for your nice introduction. I have the pleasure and honor to speak today here in Brussels Congress, and I will tell you why I use inhaled sedation and how I integrate the ABCDEF bundle in my ICU. And of course, I have some disclosures. We have funding and speakers' fees I received over the last 13 years, I have to say. So what I'm going to speak about today is about the evolution of sedation and how we can integrate volatile sedatives in the ICU and how we do actually the ABCDEF bundle in my ICU. Sedation has become a very entertaining story in the last 20 years, and you might say, oh, this woman is going to talk about sedation again, and oops, yeah. But actually, it's something that really we have to care of in our ICU because we have learned over the last 2 decades that sedation promotes mortality, longer ventilator time, and ICU times. So what has been found and implemented in many ICUs that you have a nursing implemented sedation protocol, you use a daily interruption of sedatives that has been brought from John Crest, Chicago, and then we have found out that not only awakening, but breathing trials spontaneously every day brings us a shortage in ventilator times. And then it was seen that early deep sedation is associated with long ventilation time and higher mortality. And when I look about the German guidelines, I had to find out that in the last years we had light sedation as key and king to come in our critical care setting. But if I have a close look at my patients, I have to admit that there are many of our patients I cannot just go for no sedation because they are critically ill and because they have impaired oxygenation and they intubated because they suffer from ARDS. So I had a close look of what is promoted in the last years, and this is one of the most cited articles we have from Strom, which highlights my idea of sedation in the ICU. And as you can see, we have 2/3 of our patients that are unsuitable for no sedation. So it means that these all need to be sedated in some way, and those with no sedation in this group, at least they had more than 6 hours of any sedation. And what they said, they had an increasing stuff and haloperidol to use, which I usually don't use very much in my ICU. So this sounds good. If you have a patient that is awake, comfortable, not in distress and safe, I can use a no sedation protocol. But all the others I see in my ICU that are really distressed and impaired, I have to think about how I can perform sedation with doing a good thing in my patients and what kind of sedatives I'm going to choose. And the question was raised in the latest PADIS guidelines from the US from 2018 to see does light sedation really comfort our patients and do anything in the outcome of the critically ill patients on the ICU. And it was stated that time to extubation, there was a trend towards better outcome, but mortality was not changed, especially in light sedation was not associated with delirium or reduction in delirium or PTSD or depression. So light sedation is not really a strong recommendation nowadays. You should use daily sedation interruption protocols and nursing-driven sedation, but we are not sure if no sedation is really king when we use and treat our patients on the ICU. So I would come to the ABCDEF bundle because it looks for me very familiar not to use only a protocol for one thing, but to see the whole scenery of our patients. Because they intubated, and the moment they intubated, I have to have a strategy to make a weaning and get them out of the ICU again. And this ABCDEF bundles combines all different factors we use in the ICU, coming from analgesia first. This is something we always have to do. Then it integrates spontaneous awakening trials, spontaneous breathing trials that you should perform daily in your ICU. And then you should have a close look at the choice of medicaments you have on your ICU for analgesia and sedation. And you should assess, prevent, and manage delirium. You should integrate some kind of a protocol, have an early mobilization and exercise in your patient, and family engagement is something new that came in just lately that you can use on the ICU with your critically ill patients. So looking upon the context-sensitive half-time of our sedatives we are using nowadays, I have to admit it made me think of an ideal sedative. What is it, an ideal sedative, if I use it? It should have a rapid on and offset of action, low metabolization rate, easy to titrate, no accumulation, no ceiling effect, and especially no active metabolites, like we have in midazolam. But it's going even further, because this context-sensitive half-time was taken from healthy persons. But if I think of my ICU patients, they mostly suffer from inflammation, sepsis, ARDS. And then we have a totally changed distribution in our patients. You can see here fluid resuscitation, altered protein binding, and finally resulting here in a difference in pharmacokinetic properties. So it might be quite different in those patients using midazolam, lorazepam, or even propofol. And I'm an anesthesiologist, and it's quite easy to use volatile anesthetics on the ICU for me because I'm so familiar to them. Many decades we have used the anesthesiologists volatile anesthetics on in the OR. They are safe, they have a low metabolization rate, and this is why I started 13 years ago to use volatile anesthetics in my ICU, because it was just half a mech and I didn't really care about the concentration, and I was convinced doing a good thing to my patient. So, and it was the turn of the millennium when first there was a device, a medical device to give inhaled sedation easily in the ICU, which is the anesthetic conserving device. And it can be used nowadays with isoflurane and sevoflurane, so I will just skip the desflurane and stick to those both agents we are using nowadays in the ICU. And the first study that I faced when I started with inhaled sedation was coming from Peter Sacke from Karolinska Institute in Sweden, and he made a comparison between propofol and midazolam. And what he actually saw was this short wake-up times, around 10 minutes compared to midazolam, and extubation time, of course, was short as well. And he saw that those patients had less agitation and withdrawal, even after a follow-up of 6 months. There seemed to be no hallucination and delusions in the isoflurane group. And there, when I started, I was during that time working in cardiac surgery department, so I was keen to see how sevoflurane would work in my patients compared to propofol in the post-operative period. And it was interesting to see, because I was convinced that propofol is the shortest sedative for wake-up we could have during that time. And it was astonishing to see that we have a great difference between our groups here, between propofol in blue and and sevoflurane in yellow. And the wake-up was very, very quick, and we had a shortage in ventilator time, of course. And by the way, when we did our study, we found that length of hospital stay was shortened in the sevoflurane group compared to propofol. And in the next years, there were many other studies coming that were involved in inhaled sedation on the ICU for different topics, different patient groups. And I just want to highlight in this one from Mesnil, the group from Montpellier. They did a comparison between sevoflurane, propofol, and midazolam. And this is actually highlighting what we already saw before with the sevoflurane propofol group, that within short of time you have an awakening, and you can see here the extubation times as a mean for the different groups. So this was absolutely convincing. And we had another co-effect here that you can see in many, many studies involved with inhaled sedation, that you can have a lower rate of morphine or opioid consumption up to 24 hours, which comes in many, many other studies. So we use today in Germany in many, many units inhaled sedation, and especially those patients that come in resuscitated to the emergency department, and they have to have a temperature-targeted management. They are often difficult to sedate. You start with propofol, you go with midazolam, still they have shivering, still they awake, and you need a good and deep sedation for more than 24 hours. So it was obvious that now we face different studies where our colleagues highlighting the positive effect of inhaled sedation in these special cases. And as you can see here from Kranich and colleagues from Charité Berlin, they did a retrospective analysis over 5 years, including patients either having received IV sedation or inhaled sedation. And what they finally saw was a reduction in ventilator time of more than 4 days. So I'd say this is really a high topic, because 4 days in patients that have been resuscitated, where you have a neurological assessment very, very early, is absolutely convincing. And we have, of course, a shortage and length of ICU stay as well. And this is how it looks like, for example, on my ICU where I work, and I established the Anaconda, the anesthetic conserving device. For those who have not been concerned with inhaled sedation coming from other countries, you might see here the device here exactly at the time when you have, at the place where you have the HME filter, you have the white piece coming from the ventilator. We do suctioning, we do nebulization in these patients as well, and we have a gas monitor just to be sure with our concentration that we set with alarms. And you see that this is a neurosurgical patient with the ECP here. You can see here the online measurement as well. So we use it even in neurosurgery. There had been several meta-analyses in the last years looking upon reduction of extubation time and duration of mechanical ventilation. So this one was performed by Angela Gerath from Toronto, Canada, and she exactly saw what others have brought to us. The thing that we have this difference between IV sedation and inhaled sedation. And for me, it's quite easy to use inhaled sedation, because inhaled sedation started up in Germany very, very early in 2005, 2006. And already in 2010, we had inhaled sedation in our guidelines. So this is the latest guideline we have in Germany from 2015. And as you can see here, not to confuse you with this picture, but just if you have a look here where it says, is there an indication of sedation, then you should see what kind of aim of REST score you're going to have in the end, and what is your choice of medicaments. And choice of medicaments first is propofol, but then it's indicated you have an option for volatile analgesia, and the second is midazolam analgesia. And what they described is that patients who are mechanically ventilated via an endotracheal tube or tracheostomy can be sedated with inhaled anesthetics as an alternative or to IV sedation. And the inhaled sedation is achieved with volatile anesthetics, of course, which are commonly used in general anesthesia. This is COR, but in much lower doses. We usually speak of up to half a mg. And we are now facing one outcome study coming from University of Bochum, where they investigated retrospectively patients being ventilated for more than 4 days. They divided the group, did a match pair, and had IV sedation compared to isoflurane. And what they actually saw, if you have a look here, they had more hospital-free days. That was significant here after 180 days. But they highlighted mortality, and this was quite interesting to see. These were patients with sepsis, 90% septic shock, with high Apache scores, and the mortality is quite different. It differs hospital mortality more than 20%, and 1 year mortality, it's as well 20%. So that might be interesting in the future if what's happening in these really severe and critically ill patients, how the outcome of this patient group is. But it's not only limited to adults. I'm usually just treating adults in the ICU, but I know that there are many colleagues, they are working with children. And this is not a new concept. Children have been treated, but only in status asthmaticus or status epilepticus. And when my colleagues, the pediatricians, they asked for an anesthesia machine in the 19th to bring in their ICU. So this has become quite easy nowadays because you can use the anesthetic conserving device at the bedside. And this is just one case. This is just one case report highlighting what's happening in this child with this severe asthma and how they could resolve it with isoflurane within half an hour, and the patient was extubated after 18 hours. And there are other groups. This is one investigation from University of Cologne where they highlighted that especially children with small gestation age, just 2-3 kilograms, having problems with the heart and with the lung, they have to be ventilated on a long term. What are they going to face? And the problem is that they have difficult sedation, complex sedation. What do I mean with this? It means that they start with midazolam and morphine, and then go to fentanyl, perhaps remifentanil. They add clonidine, they add ketamine. And then what else do you have to sedate such a small baby? So for them, it was convincing to use isoflurane and inhaled sedation. And I have brought you the setup for this because this is something quite different than to adults. You have a setup here in the inspiratory limb for these small babies, which is different. And what they saw, and this is an experience I have quite often on my ICU, that they breathe more spontaneously than others receiving IV sedatives. And they had a reduction in analgesia and core sedatives, and for them it gives a new option to sedate these small gestation age babies. So there had been other reports, and this is where at the moment there's much interest we're putting on ARDS and ECMO patients. And there had been some case reports lately here from Andreas Meisser from Saarbrücken in Germany. He put 6 patients with ARDS and ECMO therapy on inhaled sedation. And you can see here RAS was a deep RAS score in the beginning, and he only had a consumption of 1 to 3 ml per hour by syringe pump. And what he saw as well, that he has a preserved spontaneous breathing with his patient and could wean them much earlier from the ventilator than he usually sees with IV sedation. So to come back to the ABCDEF bundle, what do I do on my ICU? For us, it's always like we start with pain management. We ask ourselves, is this patient is struggling because he's feeling pain and he needs analgesia? This is our base where we go. Then we have a protocol where we set spontaneous awakening once a day in the morning during the round and spontaneous breathing. So this is easy to perform with inhaled sedation. Either I take the anaconda out, then we know within 10-15 minutes your patient is awake. But then you have a nurse to stand with you at the bedside because it's so quickly. It's much quicker than you will see with IV sedation. And spontaneous breathing, sometimes we don't even have to do a trial because they start very, very early to breathe spontaneously. So we just leave them and give a pressure support ventilation. And when I perform sedation in my ICU, I always consider volatile sedatives. It's when you look upon the properties of these sedatives, it convinced me very early that I have to use them in my critically ill patient, and it can be an alternative for you as well to get rid of the midazolam. And delirium is something we, at the moment, don't know if we're going to do a good thing with inhaled sedation. There seems to be some hints that we know we have less delusion, less hallucination, but for me, it's more the whole concept of it. How are we going to reduce delirium? This morning there was a very nice discussion about delirium, that it is not just one risk factor, but we have many, many risk factors around our critically ill patient. So at least I think I'm using an ideal sedative, a perform awakening very, very early. I go for spontaneous breathing. Then I think I can better work with my patient and perhaps have less delirium, but still we are lacking the studies today. Early mobility is something I have integrated in my ICU. We do a lot of cycling, but we don't have enough nurses just to even make them walk or sit at the bedside. We have one nurse to care about 3 intubated patients, so this is quite difficult. No respiratory therapists. It's difficult, I'd say. We're an open ICU. We have a family engagement. They can be at the bedside even during the night if they want to, and we want to have some things like glasses, ear aids, everything that is preventing us from delirium and normal activity as well, the patient to come back to a normal life and extubate him and wean him from the ventilator. So to come to the end, I have to say that the ABCDEF bundle for me is an interdisciplinary, multi-professional team approach. Just have a look at your patient and think that you can change your rituals at the bedside. Do something new and start by concentrating on what kind of patient you have. And the moment you intubate him, you must have an idea how to get him out of the ICU. For me, volatile anesthetics are ideal medicaments with a very good profile for wake-up, early extubation. They have a very wide range of sedation depth. Can go from -5 to 0, and they have potential protective properties. I'm sure we're going to hear more in the next session. And they have been integrated in Germany in the guidelines. So this is something I use as an alternative and option in my ICU. Thank you very much for your attention.